Welcome to CLEAR Week 2023, when we're showcasing the work of frontline staff who've been delivering innovation projects within their clinical services to drive change. And a big welcome to day 2. This is our second session today, CLEAR Anticipatory Care, new models of proactive holistic care for patients while reducing pressure on primary and secondary care. And this session is focusing on the work of our recent CLEAR Anticipatory Care programme. And today we welcome speakers from 2 of the PCNs involved. Please note the webinar will be recorded so we can share it with others who are not able to join at this time. And please follow us on Twitter and share your thoughts on the session using hashtag ClearWeek, and our handle is @ClearForCare. So our speakers today are Melissa Lawton, complex case nurse from Hyde PCN and CLEAR Anticipatory Care Associate, and Margaret Macklin, CLEAR Anticipatory Care Associate as well, representing East Warrington PCN and former Head of Service within Adult Social Care. And Claire Brewster, CLEAR Anticipatory Care Clinical Lead, CLEAR Anticipatory Care Clinical Lead and former CLEAR Associate and Frailty Specialist Nurse. Thank you very much for joining us today. Claire, over to you.
Thank you. Hello everybody, and hope you enjoy our session that we're going to share with you this afternoon. So if we can just move on to the next slide, that would be great. Thank you. So we've just put this graph of map of England on really just to kind of highlight where we're up to with the CLEAR programme. And we have been providing rapid support and training to the NHS since about 2018 now, and supported during COVID-19, and then we're continuing to support the NHS in restoring and transforming services across England. Oh, if you can just go back, sorry. Thank you. So this map just shows really where we're up to with our projects across England, and we, as you can see there, we've done a lot of work in urgent and emergency care, critical care, mental health, and the anticipatory care programme is the one that we're going to talk about today. CLEAR stands for Clinically Led Workforce and Activity Redesign, and it's led by transformation programmes led by clinicians with help of data analytics and management consultants and local clinicians to try and help improve services. And to date, we've done 40 plus projects across England and empowered more than 100 clinicians in there. So if we can just move on to the next slide, please, Suman. So the AC programme, the Anticipatory Care programme, we worked with 5 PCNs across England, and it was undertaken between January and July last year. The 5 PCNs were a total of 40 GP practices altogether, with serving a population of about 300,000, and 12 staff were taken through the programme from these PCNs, and we went through the methodology of CLEAR. So that involved 120 engagements with staff through clinical engagement, and then we extracted data from 40 GP practices, up to 5 years of GP data from the 5 PCNs. We then looked at key challenges, and we'll talk about those later in the programme. Just go on to the next slide. This is just a high-level key challenges and findings overview of what the all the 5 sites found within their programme. So they were experiencing a range of common and interdependent challenges that created pockets of vicious circles really, and it was as complex as that diagram looks. It was really, really difficult to try and get down to the real key challenges and try and find out what the issues were. There were a lot of interdependencies. The main 3 that we came up to were variable integrated care and care coordination for patients with long-term conditions. And as we know, patients now have got more complex needs than ever, and it resulted in more pressure on GPs. The acute workload for GPs and for primary care staff was providing a barrier to provide holistic care, and we were very reactive rather than being proactive with our care, managing services on a day-to-day basis really. Discharging patients to primary care from secondary care seemed to be a great big problem, with a lack of communication to other services, and services not really talking to each other either really. Another one of the main challenges that we found were the challenges with data collection, coding and information sharing. The existing data was not made available to all within the service or the PCN. There were incompatible data templates which prevented care from being adequately standardised and shared. Ad hoc care planning as opposed to proactive care planning, and there was an awful lot of duplication of work. Inequity of access was another big area that all the sites noticed and worked on. Inadequate tailoring of appointments and care plans to patient-specific needs, and it was particularly detrimental in relation to care for high-intensity users, but also for patients from the lower deprivation deciles, and we found that. So our next step then was to pull all the clinical engagement and the data analysis together and to try and think about some innovation and how we could looking at some high impact changes and pulling the key challenges together. So we've got the key recommendations on the next slide, Suman. And this really is a thematic overview of the key recommendations at high level. So our first one was communication and how having proactive care needs assessment, multi-agency working, common language available to all, and carer support at PCN level. That was really one of our main key recommendations. The intercollaboration between the ICS and PCN level, so for social care and healthcare teams to work together more, look at record sharing and really focus on the multi-agency working. Data sharing, system design and demand, and using existing tools more effectively. I think everybody knows that we've got the data and the IT systems in place, but a lot of the time we don't use them as effectively as what we could do. Understanding local needs and challenges and empowering the community was another big one for us. And we all found that even though, we'd got 5 different PCNs over England, there were some differences locally. And PCNs have their own local challenges as well as the national challenges that they were to meet from the demands there. Excuse me. And then finally, we looked at workforce. We looked specifically at new ARS roles. We linked in with the ICS. We tried to have a proactive approach and looked at upskilling existing staff as well as looking at new roles and responsibilities within the workforce. We tried to be system-wide, so we tried to link in with new roles within social care and how we could kind of extend communication out of primary care and more into that wider collaboration of people who would support patients in a more proactive way. So now I'm going to sorry, no, I'm not. I've gone a bit too quick. So these are our recommendations for transformation. So we looked at new models of care and we looked at new ways of working, and the new skills mix in the middle was where it overlapped. So areas that we looked at in the new models of care was triage and care pathways. So how we could kind of get patients on that journey earlier in the diagnosis. So like for dementia patients and patients diagnosed with frailty, how we'd kind of get those involved in services earlier in their journey. How we could look at preventative care, so how we could identify patients who were at high risk of developing long-term conditions and how we could support those earlier, and look at how we could integrate processes within that. The new ways of working, as I've already said, is looking at new roles, how we can improve communication, so how we can improve communication between primary and secondary care, and also around the wider support systems, and how we can enhance skills of staff that are already in post. So that's my little bit, an whistle-stop tour of introduction. Have we got any questions so far? If not, I'm going to hand over now to Melissa. And Melissa's one of our associates that is from the Hyde PCN, and she's going to talk about their work in Hyde. Thanks, Melissa.
Thank you. Okay. Hi, yeah, so I'm Melissa Lawton. I work as a complex case nurse in Hyde, which is just outside Greater Manchester. It's made up of about 8 GP practices working together. So if we just go to the next slide, please. Thank you. Yeah. So altogether, we're covering about 70,000 patients amongst those 8 GP practices, 7% of which from BAME communities. Now, 48.3% of Hyde's population live, in the 20% most deprived output areas, which is something that we were aware of before, but actually we didn't realise how high that number actually was until we started doing this. We do our life expectancy in Hyde is lower than national average, and we do have a lot of dementia patients, which obviously with our vasculars could be down to the fact that the poor lifestyle that people are leading. Now, we were finding as well that we have a lot of patients going into hospital. They generally don't come out, and that's not always the best place for our patients. And that is the reason why we chose dementia patients as our cohort, because we are aware that they are disadvantaged. So we did go with that cohort of patients. Okay, if we go to the next slide, please. Okay, so through clinical engagement and the data analysis, we then triangulated our themes, and things began to emerge, different themes and challenges, some of which we were aware of, some of which kind of came to light during those phases. The first one, as Claire touched on before, which is, I believe, you know, will be a national problem, but also very present in our PCN. So that is communication. Now, we were finding that the organisations are very, very poor at communicating, and also because of the IT systems that we use, they don't always match up, and we can't always view each other's records. So we were finding that a lot of work is being repeated, and actually it's not the best use of a clinician's time. Also, we did find as well that there was very poor knowledge of people's roles in other teams. It was very much kind of, you know, people were working siloed, and they were quite happy to continue doing that. And it's only from doing this that people have been able to learn more about each other's roles, which leads me on to obviously our second one, which was lack of collaboration. Now, we were finding with our mental health team, with our dementia patients, that we were sending out referrals. These referrals were being rejected, but we weren't actually finding out why that would be. We were getting no feedback from it. And then you would get a little bit further down the line and realise that actually there were multiple services working with these patients, but nobody actually knew about this. So, you know, patients are ringing up and you're kind of thinking, right, where do I direct them? Actually, they're already known to this service, we could be doing this. So this was something that came up as well, that we need to be working more collaboratively rather than in our own silos. The third theme that we got was inequality of care. So we did find, which we did suspect in the first place, that, you know, patients without capacity are treated slightly different to those with capacity. For instance, you know, when they maybe rang the GPs, they're suffering with a dementia diagnosis, they're not sure where to go. They may not always be as forthcoming as maybe patients with capacity, so it's quite easy for these patients to get lost in the system. And also we did find with our mental health services that they all have referral criteria, but that's not always visible to people that are trying to refer in. So it is quite easy for them to reject it, and you don't always understand why, because there isn't actually a shared referral criteria. And lastly, accessibility was a big theme that we found as well. And, you know, how do our patients get to these services? Where, you know, where are they? Where do we access them? It's not always very clear. Okay, so the next one, please. So from our data, that's the qualitative and the quantitative data, what we found, we came up with a dementia case manager role. And how that would work is we have a single point of contact for patients, families, carers that they can ring it. So basically we were looking at it from diagnosis of dementia to death. You will have one case manager overseeing all of that care from diagnosis to death. So if that patient or their family has any issues, the service that they contact is the dementia case management service. So it's very easy to keep track of these patients and they're not getting lost in the system. Another aspect of the role that we thought would be really helpful would be hospital in-reach and outreach, because as I'm sure you're aware, once these patients get into hospital, you know, they're going through A&E, the doctors that are in there aren't aware of these patients' baselines because they don't actually have contact with their case managers or the nurses that see them regularly out in the community. So by doing in-reach and outreach, we can, you know, either avoid the hospital admission to begin with, or we can get the patient out quickly and be back in an environment that's conducive to their health, because obviously being sat in a bed for weeks on end, becoming deconditioned, is not something that we want for these patients. The third one was proactive care planning. There's recently been a big push for this anyway in our area with advanced care planning, but actually for these dementia patients, having these conversations early, you know, we are aware not too early. At first, when people are diagnosed, you don't want to be discussing this with them, but as the journey progresses and before they lose their ability to say what they want, we really need to be getting some robust care planning in place so that we can prevent things happening like hospital admissions, you know, patients dying in hospital. That's not where they need to be. And another aspect of the role would be a healthcare professional phone line and email that will be checked. That it will actually be checked. It will be every day of the week, but then also there will be somebody on out of hours to check that. So if there are any issues, you know, a hospital needs to ring for an update of, you know, we're really not sure about this patient. What were they like when they were out with you? They'll be able to get in touch with somebody straight away. You can say, you know, that's not usual for them. So that will be another aspect of the role. As part of the role, just as a kind of a quick win, QoF dementia care reviews will be completed automatically because we're dealing with these patients, which also is a knock-on effect for the QoF targets. And the other part of the role is the coordination of care across teams and services, just to make sure it's a little bit more joined up and we're kind of not duplicating work. So that's where we got to with that. So if we go to the next slide, please. So yeah, this slide is about the implementation of the service. So what we decided, looking at the amount of patients and the amount of input that we're expected to have for them, it will be done an MDT approach, but there will be one case manager. So it's 1.2 whole-time equivalent, a band 8A nurse, who will lead the service, provide line management, but also manages caseload as well of patients. Then we imagine that it would have 2 band 7 nurses underneath that nurse, also each holding a caseload, and then band 4 coordinators, 1.5 whole-time equivalent, who will be able to kind of deal with all the phone calls and direct them to the right places so the clinicians can just carry on doing the work. Now, so far, there was 354 patients identified on our PCN database. And the PCN hub will support all 8 of these practices. And as I said before, it will be from 8:30 till 4:30 with an on-call rota for out of hours as well. So the next steps of the project was, once the report was done and the programme was finished, the report went to our PCN and they decided that they would like to go ahead with the service. So my colleague who I work with, another nurse, Emma Maguire, she is actually heading up that service now. She's taken that forward, and I believe she is actually going to do a presentation for you on how that is actually going for her. But I can tell you she's very much enjoying it, and it seems to be going extremely well. So, however, we have to say at the minute, the PCN, they're running it as a pilot. So they've not taken on every single one of our recommendations. So at the minute, we've got one nurse, which is Emma, and we're doing this with one GP practice, just to kind of see where the land lies, not take on too much too soon, because obviously we want it to be successful. And it is very much an evolving service, but it's been very well received by the PCN and also the patients that are coming through and working alongside Emma. So it's been so far so good, and everything seems to be going really well. And And obviously, without the CLEAR programme, it's fair to say that this probably would not have been put into place, because, you know, we're all very much, we think we know what the problems are in our workplace, but actually, without the evidence to back them up, you can't really expect people to change. And I think CLEAR gives you that kind of evidence base, that support to kind of, you know, reinforce what you're saying, and you need that in order to make changes. So yeah, it's all going really well. And as I say, Emma will update you further when she's on Friday. Are there any questions? No? Fine.
Well, you've got a question from Dee Bailey.
Oh, lovely.
Yes, just a quick question. Sounds fabulous, really fabulous. Excited to see how it happens. I was just wondering what outcomes you're collecting to continue to evidence that this is the way forward, because we all know it's the way forward.
Yeah.
And as you said, it's that evidence base that really pushes it through.
So in order to measure it, as I say, Emma will definitely be able to fill you in more, but I think what they will be doing is looking at hospital admissions. For these patients, they will be looking at preferred place of care, preferred place of death, whether or not that's, you know, happened the way that it should have done. They will be looking at QoF targets. They've got quite a few key performance indicators that they are going to use in order to kind of measure the service. They're just the ones that I know about, but as I say, if there are any more, Emma, I'm sure will fill you in on that.
And how long is the pilot for? How long have you got funding for this?
Well, funnily enough, I think this was started only a couple of months ago, and they're already looking, there was talk I overheard the other day of recruitment for another nurse, so they're already looking at expanding this. Yeah, so, and I mean, am I right in saying this, Claire? The funding for the anticipatory care came from, lost my word finder. Where did it come from?
From our national sponsors, you mean? NHS England. So we were, we were asked to kind of do some work around anticipatory care, as it was called then, before the actual model was launched nationally. So our kind of remit was to look at some long-term models of care and how we can incorporate a proactive care model within the 5 PCNs, and how would how that would look really in practice.
And I think the PCN, I think they seem to, you know, obviously we've got our KPIs to measure it, so for our quantitative data, but qualitatively, the PCN, I think the reason they like it as well is because, you know, they got a patient who has got dementia, who's got quite complex needs, they don't really know what to do with them. It's great, they can just put them through to the dementia case manager. That's, to them, is, you know, to these GPs, that's worth the weight in gold anyway, because the amount of time that they're saving having to deal with all the kind of, because a lot of the time we're looking at social aspects and signposting, things like that, and to be able to take that away from the GPs, it's freeing them up to do so many other things. And I think they're kind of seeing that, and they're really keen to pursue it, really.
Yeah, it sounds really exciting. I might be in touch with further details outside of this meeting.
Of course.
And Dee, just to let you know, the Emma Maguire who they're referring to is, unfortunately, she couldn't make this particular session because I think she's on course. So she's actually speaking on Friday in a 10 o'clock session on the impact of CLEAR. So we can forward those details to you as well. I think they've just been put in the chat for you. So if you want to sign up and listen to her as well.
Thank you.
Anyway, is it time for Margaret now?
It is, yeah. So our next speaker is Margaret Macklin, and Margaret was part of the East Warrington team. Margaret's got a long history in social care services, adult social care services, and she was one of our associates on the programme. And it was wonderful having somebody from social care as part of being, you know, CLEAR associate on the programme for that different kind of lens through anticipatory care. So without further ado, I'll hand over to Margaret and she will share her experience and findings. Thanks.
Thank you very much, Claire. Thank you for that introduction, and good afternoon, everybody. So yes, I was one of the two associates representing East Warrington PCN, and we were working to a clinical sponsor, Dr. Raj, who was actually very, very well established in the kind of strategic partnership arena in Warrington, which perhaps made this project slightly unusual. There was always going to be a strategic question, and they were anticipating recommendations that potentially could be rolled out across Warrington and also linked to the Northwest Ageing Well programme. Okay, so I think if we take the first slide, the challenge, as really reflected in the previous presentation, was the PCN, as with other PCNs across the country, were facing unprecedented demand, and they were conscious of how they were failing people living with frailty. They were aware that care was increasingly reactive, and they also felt they were increasingly isolated. And a bit like Melissa said, they were conscious that they were finding out after the event that some of the patients that they were spending a lot of time thinking about were actually known to many other services, and it was the practice themselves that were quite isolated from that. They were aware that the underlying issues were becoming more complex, and they were aware that they needed to work more in partnership. And as part of that, the whole information system was making that more challenging, and even in relation to secondary care admissions, as we've heard already, these kind of things were really making them isolated. So they wanted to look and see if we could develop more holistic approaches to address some of the complex underlying issues, and the strategic partnerships were ready across the integrated care system to hear what we came up with. So for us in Warrington, the focus was going to be on people who would warrant a frailty score, and the chosen frailty index was the Rockwood. And one of the challenges to us as a team was where in that Rockwood scale would we focus. So next slide, please. So I think, you know, what I wanted to say was I was actually a very experienced project person in a number of roles that I've had and held. I've commissioned and been involved in projects. And one of the things that I really, really liked about the involvement with the CLEAR project was the pace of it, and this idea that you're working with other sites across the country that are tackling a very similar issue. And it gives you a natural kind of peer network to talk to about the challenges that you're finding, both with applying, you know, applying the project itself and learning some of the new tools, and also in your findings. And there are some really, really helpful tools, and the pace of the project in looking at the 4 different phases is so helpful in terms of actually delivering a project on time. In addition, you know, CLEAR has got good credibility around the PCNs and around Department of Health, which means that the fact that you've used CLEAR methodology and tools, and that this is you can, you know, you have the clear hallmark, if you like, of this evidence base. It means that people take it much more seriously. So in the clinical engagement, we conducted over 50 clinical engagement exercises, and that was from frontline to managerial levels and across health, social care, community and voluntary services, to identify that experience of working with this frail population. And we also conducted a number of focus groups to drill down in key areas. We had 3 GP practices in our PCN, and we trawled in of 30,000 records using the bespoke CLEAR platform. We were able to drill down and look at a number of queries by patient type, patient characteristic, interventions, and we were able to draw some hypotheses from that data, and also some key recommendations, sometimes due to the limitation of data as well. Also, that because we're involved with CLEAR, we were given easy access to local data from the former CCG and from the integrated care teams, and we were able to use that as well in our triangulation. And due to the CLEAR, you know, working with CLEAR meant we were able to have good access to some of the emerging practice, some of the excellent emerging practice around the country, and we were able to participate in some direct dialogue with people who were leading that change and access a whole range of research. So all of these things help provide a really solid evidence base for our recommendations. So the next slide, please. So we hadn't, there were many findings and many recommendations, but the overall finding is that patients living with frailty are taking up a disproportionate amount of GP, A&E and secondary care resources, and this is not serving them well. We actually found that people with mild frailty had the most GP time per patient, and we were also able to evidence that frail people admitted to hospital, the vast majority, I think it was 80%, had no substantive procedure while they were in hospital. So huge burden for acute reactive services that are not serving people well. So the rewards are huge in trying to bring together some proactive care that addresses problems at an earlier stage and helps divert people from the use of the acute NHS services. And we came up with a model a bit similar to the one that we've heard, focusing on dementia, but one focusing on ageing. We called it an ageing well team, again led by an advanced practitioner, and with a care coordinator, a specific coordinator also to support carers, a clinical pharmacist and some admin linked to a GP, lead ageing well or frailty GP in each practice. And we were able to show that with a very modest investment, there was the potential to shift a lot of appointments from GPs over to the ageing well team and to actually impact on A&E admission, A&E attendances and emergency admission. But one of the things we really did want to emphasise, because it hit us really in the data, that frail patients with carers access more GP appointments than those that don't have. And when we noticed that, the other sites looked at their data sets and identified the same thing. And what was concerning is that the GPs didn't feel that these appointments were in the home necessary. So, you know, carers, the only service that all carers receive is primary care service. And we were able to identify that actually the carers were largely very well known by practices, not always indicated as carers on the system, but they were very, very well known. And yet it was only when carers were facing breakdown or feeling totally unable to cope that they were being actually picked up by partner organisations such as social care. And this is a huge missed opportunity. And we were able to do a short pilot that confirmed that there were carers not being identified on the GP practice systems. And we really think that having a team that carers can go to earlier on at the appropriate level to be signposted to the wider service offer for carers, whatever it is. And perhaps when somebody is suffering towards the end of life, a team that they can go to help them navigate some of the complex relationships that they were having with a number of care professionals, and divert people from actually going to A&E because they don't know where else to go, was a really big one, which I thought was worth at least 3 minutes of my time. So next slide, please. So our 6 recommendations were that we must agree a common approach to the identification and coding of people most likely to benefit from anticipatory care. And for us now in Warrington, we think that was a focus on the Rockwood 4 and 5, so the mild and moderate frailty. I think in time you might you might try to intervene even earlier. Our Ageing Well team that we recommended also brings the ability to triage cases and ensure that they are given information and advice or referred for care management at an appropriate level in the system, either within the team itself or potentially when required in a multi-agency environment. And we came up with a triage pathway. It's so important that we improve connectivity between primary care and the wider services that working with the same patients. And we trialled the key people, a care coordinator and lead GP and pharmacist, tapping into the existing multidisciplinary meetings that the integrated care teams were running. They found it highlighted just what duplication and lack of knowledge there was in the primary care team about what was available and what was already happening, and they've carried on doing that. I've already said about improving care identification. That was the 4th recommendation. And then some more strategic ones, but it's so important that primary care has a voice within the integrated care system. It's very hard for practices, small PCNs especially, to find the time to work with partners at a strategic level. But if they don't, then all of this valuable knowledge and learning about what's not working well in primary care won't feed into the solutions that people develop. And running alongside all of this, at the end of the day, lots of people were still managing to get doctor's appointments and go to A&E, even though it's challenging, because they just didn't know what else to do. And it's so important if you can provide places, especially in the geographies where people are most struggling with complex problems, if you can provide alternate routes for people to go with a problem and talk to someone and have them looked at. And that's what they're doing subsequently in Warrington now. They've identified these 6 talking points at key parts of the town where people can go, and it prevents them going to GPs as a first point of call. So they were our recommendations. And then just, I think this next slide has got little detail about our model, but I think perhaps we don't have a lot of time to go into it. But I was really impressed with this part of the programme because it helped us quantify what the possible shift could be on the system in terms of reduced GP appointments, reduced non-GP appointments, A&E attendances and emergency admissions, and for what is a very modest outlay of £60,000, of which most of it, £55,000, is potentially eligible for something called the Additional Roles Reciprocation Scheme, which means it's actually paid for nationally. You could expect to see an impact of about 144k. In real terms, you're unlikely to save money with this, but what's probably more valuable at the moment is freeing up GP appointments and emergency admissions, which I think brings me to the last slide, which is what's happened in Warrington. And unfortunately, we've not actually trialled the model, the Ageing Well team, as we've just heard about from Melissa. They're still trying to identify funds to do that, but what they have done is strategically the partnership, the place board, has accepted the recommendations, and they've created a working group to look at how our recommendations can be implemented across Warrington and linked to the work that's been done on the high intensity users, the work that's happening with the virtual wards around frailty, these community talking centres, and the development of the integrated care team. So there is a will to do this. That's been taken forward. But the primary care network East Warrington does now formally link into the multidisciplinary team meetings in their local integrated care team, and are finding that very beneficial, and that's given them a route to escalate some of the more complex patients. And the Carers Board in Warrington has accepted the recommendations on carers and has developed a work stream around how to support carers better from primary care. And another outcome is that all social services directors are part of a national group called the Association of Directors of Adult Social Services, and they have a work stream on carers, which I think works with the Department of Health Commitment to Carers team. And they have accepted the recommendation about primary care sort of on a national level, and accepted that as a priority, one of their 5 priorities in their current delivery plan. So, you know, I think there is a possibility that that could get more attention, although often, you know, strategic change lags a long way behind actual operational delivery. But that's what's happened subsequently.
Lovely, thank you very much. Any questions for the panel? I had a question. What people are thinking. I had a question with regards to the with regards to ADAS, Margaret, and how did they get to hear about the carers recommendations that you put forward?
Yeah. So as I say, a lot of it was to do with the strategic commissioning, really, of the CLEAR pilot in Warrington, and the director of social services, a woman called Kath Jones, worked very, very closely with the place lead, a man called Carl Marsh, who was previously from the CCJ, and they were very convinced by the arguments in the CLEAR programme. And Kath is one of the 150 directors of social services in the country, took it to the National ADAS Carers theme group, and that group isn't just directors of social services. They've got at least 4 national carers bodies sitting on that group working with them, and they said it. They said they agreed with everything. They said it confirmed what they'd been finding, but what they were particularly, as I say, influenced by as well is that there was some actual evidence backing it up, and the CLEAR name. So they did ask me if I'd talked to the Commitment to Carers team and Department of Health, and I explained this was a project that's now ended. But yeah, that's how they got to hear about it. And they did ask if they could access the report as well.
Oh, thank you for that. And your involvement, as you know, from the social care perspective, were you surprised at the lack of collaboration or lack of connectivity? I think you described it as.
No, I wasn't surprised, and in fact, I was encouraged by the acceptance of a lot of the people that I came across in the project. The thing is that, you know, there are so many connections that people are having to make within the NHS already, and you know, like everybody else, they're just besieged. And I can quite understand why the development of specialist teams is happening, because, you know, GPs and nurses who are identifying a problem just need somewhere to pass it on to. But the thing is that certainly in Warrington, and I don't think it's unusual, the other partnerships are getting increasingly connected, community voluntary and adult social care. And I don't think the NHS needs to, recreate this. It's there. It's about working out how to connect to it. And I think triage, you know, is one of the really useful tools. And I think the team we designed, the idea is that through talking to each other and just doing a little more work around a person, you can say, actually, this can be managed within the team, or this is a case we need to take to the multi-agency and it might need care management. And we might be able to sit back with a lot of this, you know.
Thank you. Annabelle had a question.
Hi, I'm Annabelle. I'm a delivery leader at CLEAR, and it's been really interesting to listen to your projects and also to hear about your experience. And I wondered whether you've used any of the things that you learn on through the programme in your sort of daily lives since in other work that you've done?
Do you want to answer first, Melissa? I mean, I can answer. I'd actually retired. I'd actually just retired when the CLEAR pilot, and they were really struggling to find a second associate. And in Warrington, they were really keen to have somebody from the partnership arena because they'd already identified that we needed to work holistically with patients. So I was persuaded to do the pilot, and one of my desired outcomes was that I could pass on some of the learning to people who were carrying on working. And to a certain extent, we tried to do that. But I think, you know, I do like the CLEAR model where people are actually working in a setting and do the programme and then retain the skill set, you know, for themselves and in the location. But that wasn't something we could wholly do in my case.
Yeah.
Lisa, did you want to add anything?
Yeah, and I mean, I think the thing is, on the next presentation in the personal journey through CLEAR, I'll go into it a little bit more, but I think the skills that you get from it, they're invaluable, really. You know, there are so many things that you get from it that you didn't even realise that you needed. You know, it's improving your soft skills, your hard skills. There's everything. There's all these things that I kind of really felt not very comfortable with, really, that I was a bit oh, how am I going to deal with this? And actually, once you get into it and you start working with people, you do take so much from it, and it's been really beneficial, both professionally and personally. There's been a lot offered, so I would definitely recommend it.
Thanks, Melissa. Claire?
Yeah, I was just going to reinforce that, really, and just say that I think as nurses as well, we're never data driven, are we? And we kind of just get on with the job and do the work, and we know that there's issues and, you know, crises from day to day, but not just with staffing, but with patients and workload. And I think with CLEAR, I know when I did it, you know, back in the UEC programme, you actually had that data to evidence what you were talking about, and it's so powerful. And you can actually tell patients stories around the data, and the clinical engagement gives you, you know, that real richness of talking to other services and, you know, create, you know, just talking about stories and patients' experience. So yeah, I think you're right there, Melissa.
Yeah.
Something that.
Thanks, Claire. Just checking if there's any more questions. Don't think there is. So just let me say many thanks to all our speakers and everyone who attended today.